Hello and welcome to this PCR webinar on imaging essentials in atrial secondary tricuspid regurgitation. My name is Denisa Muraru from the University of Milano Bicocca, Italy. It is my great pleasure and honor to be the host of today's webinar. This is the first episode of two webinars that are going to be focused on imaging tricuspid regurgitation organized by PCR Tricuspid Focus Group and made possible thanks to the support from GE Healthcare. Atrial secondary tricuspid regurgitation has been only recently identified and characterized as a distinct entity from the ventricular form of TR. However, to date, it still remains underappreciated. Therefore, the learning objectives of this webinar are to have a better understanding of atrial secondary tricuspid regurgitation, including its imaging characteristics, distinct pathophysiology, and current management. We would like to learn how to quantify TR, tricuspid annulus, and right chambers using the most advanced 2D and 3D imaging tools. And finally, to know how to perform patient selection and intraprocedural echocardiographic guidance in patients with atrial secondary TR. Today, we have the opportunity to listen to three world-class imaging experts in imaging tricuspid regurgitation patients. They will be sharing their insights and their personal clinical experience, also some very interesting real-life cases. So we will be here today with Professor Luigi Bedano from Milan, Italy, Professor Marta Sitges from Barcelona, Spain, and Professor Nina Wunderli from Langen, Germany. Welcome to all of you today. Thank you for joining me in this webinar. And before getting started, I would like to remember the audience that you can address your questions via chat, and I will hope that we will be able to address most of them during the webinar live. Now it is time to introduce the first speaker, Professor Luigi Bedano, who will present the phenotype of atrial secondary tricuspid regurgitation, imaging and management concepts. Please, Luigi.
Thank you, Denisa. Thank you to GE Healthcare and the PCR Tricuspid Focus Group for the invitation. Really honored to join Nina and Marta for this webinar. So during my next 15 minutes, I will try to address several points. And first, why atrial fibrillation can cause secondary TR, how to make the differential diagnosis between the atrial and the ventricular phenotypes of secondary TR, how differs the remodeling of the right air chambers in these two distinct phenotypes, and which are the clinical peculiarities and also the outcome of patients with atrial and ventricular secondary TR, to finish about the diagnostic criteria that have been used so far to identify atrial secondary TR. Let me start from the very beginning. We all have grown in the medical school with the concept that secondary tricuspid regurgitation is a disease of the right ventricle, and the dysfunction and the remodeling of the right ventricle is the main driver for the enlargement of the tricuspid annulus and the onset of secondary tricuspid regurgitation. Well, this concept was challenged a few years ago by a study by Denisa Muraru and the others that look at the very large study population, including healthy volunteers and different etiologies of secondary TR, left heart diseases, pulmonary arterial hypertension, severe tricuspid regurgitation in patients operated after tetralogy of Fallot, and in patients with atrial fibrillation. And in this study was documented that in both healthy subjects and in patients with secondary tricuspid regurgitation, the relationship between the size of the tricuspid annulus and the right atrial volume was much more closer and significantly closer than the one between the tricuspid annulus and the right ventricular volume. And this was a start of different studies. And also, we were a little bit skeptical about these findings. And so we looked also for the anatomical reason for that. And this is one of the findings provided by our anatomopathologist, showing clearly that the muscle cells, muscle fibers that enter the tricuspid annulus are those coming from the right atrium, while the myocytes of the right ventricle just stops at the level of the hinge point of the tricuspid valve leaflet. And this is an anatomical substrate for the role of the right atrium into the enlargement of the right atrium. The concept was not entirely new. Several other researchers have been closer to that. For example, this is a seminal paper by Utsunomiya and co-workers from Los Angeles, showing that when they compare the size of the tricuspid annulus between normal subjects, patients with left heart tricuspid regurgitation, and a patient with tricuspid regurgitation and atrial fibrillation, both the size was larger, significantly larger in patients with atrial fibrillation than in patients with left heart diseases, but also the function of the tricuspid annulus was more severely impaired in patients with atrial fibrillation. One other important study is the one from Ortiz, Leon, Lisa Sujeng, and co-workers, that for the first time they were able to demonstrate that in patients who have atrial fibrillation, even if they had no detectable left heart disease, there was a significant dilation of the tricuspid annulus, showing the relationship between the atrial fibrillation and the tricuspid annulus. Recently, another researcher from our group, Andrada Guta, using all the available tools by 3D echocardiography, so making a quantitation of the right ventricle, the right atrium, and the tricuspid annulus using 3D echocardiography, was able to show clearly the relationship between the severity of tricuspid regurgitation and the tricuspid annulus size, as well as the right atrium size, but there was no clear relationship of the severity of tricuspid regurgitation with the detenting volume or the right ventricular volume in patients with atrial fibrillation, just showing once again the direct relationship between atrial fibrillation, remodeling of the right atrium and the tricuspid annulus, and severity of tricuspid regurgitation. This was further moved on by another researcher, Diana Florescu, that looked at the remodeling of the right ventricle and in general of the right heart structures, but we will concentrate on the right ventricle, comparing the shape and the size of the right ventricle between patients with pulmonary artery hypertension, patients with tricuspid regurgitation and atrial fibrillation, and in normal subject. And compared to the shape of the right ventricle of control subjects that you see on the left, you can clearly identify from this cartoon the different way the left ventricle remodeling in the atrial and in the ventricular phenotype of secondary tricuspid regurgitation. In the atrial one, there is not much enlargement of the right ventricle that becomes more triangular, having an enlarged base but a narrowing apical part, while in patients with the ventricular phenotypes of secondary tricuspid regurgitation, there is a so-called ovoidal remodeling with a prevalent enlargement of the mid diameter that makes the basis for the realignment and horizontalization of the papillary muscles tethering the tricuspid leaflets. Having clarified a little bit the pathophysiological basis of atrial tricuspid regurgitation, we will look at the prevalence, because one question is, yes, but how many patients with atrial fibrillation will have this develop tricuspid regurgitation? This was addressed in this elegant study published on Circulation Japanese by Abe and co-workers, that look at patients having transthoracic echo 2 years apart, and looking at those that developed atrial fibrillation. They were more than 1,000 patients, after excluding patients with comorbidities and patients who had no repeat examination, or patients with left ventricular dysfunction. They remained with 300 patients with the normal left ventricular ejection fraction and no other comorbidities. Well, from them, there was a time-dependent prevalence of the tricuspid regurgitation. Starting from the right, you see that in patients we have a very short atrial fibrillation, less than 1 year, the prevalence is really low. But in patients that have atrial fibrillation between 1 and 10 years, you see that there is a sizable number, 17% of the patients can develop significant tricuspid regurgitation. That is almost 3 times the patients who will develop mitral regurgitation. Just to put things into the perspective, I will show one rapid clinical case. This is a 74-year-old woman with no detectable cardiovascular risk factors. She was admitted to our emergency room for the first episode of persistent atrial fibrillation, and she complained because of palpitations and dyspnea on efforts. And there was a pharmacological cardioversion to sinus rhythm in the emergency department. The patient was admitted, and the day after the sinus cardioversion, we performed the echo. These are the relevant views. You see this huge gap between the tricuspid leaflets, enlargement, right atrium. I don't need any quantitation and I hope you agree with me that this is a torrential tricuspid regurgitation. We performed, this is also demonstrated by this nice 3D echocardiography showing the wide gap between the leaflet. There is an anatomical regurgitant orifice area of 0.8 centimeters squared, substantiating the diagnosis of torrential tricuspid regurgitation. We made a quantitative assessment of the right ventricle, the right atrium, and also of the tricuspid annulus, showing that there is an enlargement of both the right atrium and the tricuspid annulus. Then the patient was followed, and after 1 year, this is the repeated echo. She had the sinus rhythm throughout the year, and there was a reverse remodeling of the right atrium and of the right tricuspid annulus, with the disappearance of that torrential tricuspid regurgitation. Again, we made all the quantitative assessments that are available today on a modern echocardiography system. And then just to summarize, if you compare the two echo studies performed 1 year apart, you will see that there was no great change in the size of the right ventricle. Of course, there was an improvement of the right ventricular ejection fraction while in sinus rhythm. The free wall strain didn't change. Pulmonary systolic pressure didn't change. What was impressive was the reverse remodeling of the right atrial volume and the tricuspid annulus area that justifies also the decrease of the tricuspid regurgitation. This is a single clinical case, but very recently, Sulat, Dufour, and co-workers published in JACC the remodeling of the cardiac chambers in patients restoring the sinus rhythm. This is a relatively large study, more than 100 patients, and the patients were divided in 3 groups. In blue are patients who were unable to recover the sinus rhythm. In red, patients who had an active restoration of the sinus rhythm due to antiarrhythmic drugs or cardioversion, and in black, patients who had a spontaneous restoration of the sinus rhythm. And when we look at the changes in the 3D volumes of the cardiac chambers, you see that there is a consistent negative remodeling, particularly of the right atrium and the right ventricle in patients with persistent atrial fibrillation. Positive remodeling, again, more evident into the right atrium, right ventricle, and the left atrium in patients who gained the active regain of the sinus rhythm when they were almost unchanged in patients with no spontaneous regain of the sinus rhythm. And then when we look at the I need a reconnection, okay. When we look at the tricuspid regurgitation and the mitral regurgitation, once again, there is no change in the severity of the regurgitation in a patient with persistent atrial fibrillation. There was a regression of the severity of both the tricuspid and the mitral regurgitation in patients had an active restoration of the sinus rhythm, as well as in patients with spontaneous restoration of the sinus rhythm, confirming in this prospective population the findings that we had in our single case. So this is confirming something that we derived a few years ago, that probably the pathophysiology of atrial secondary tricuspid regurgitation is mostly linked to the dilation of the right atrium, that is the main driver of the dilation of the tricuspid annulus, and is also associated with the loss of function of the tricuspid annulus and the lack of growth of the tricuspid leaflets. Finally, looking at the outcome of a patient with atrial and mitral tricuspid regurgitation, but for the aims of tonight, we will concentrate on the left part of the slides, looking at patients with the tricuspid regurgitation. You see that the patient with the significant tricuspid regurgitation and atrial fibrillation, that means patients with moderate or severe tricuspid regurgitation, have a significantly worse prognosis than patients with less than moderate. This is also documented by a difference in patients with the 2 phenotypes of secondary tricuspid regurgitation, as shown by this paper by Mara Gavazzoni and co-workers that has been just published on Frontiers. Usually patients with the atrial secondary tricuspid regurgitation are older than the patients with the ventricular one, less symptomatic, and with a less, of course, less prevalence of other disease. The remodeling of the cardiac chambers is significantly different, as we have seen before. But what is even more important is that the outcome is different. And looking at both death for any cause and hospitalization as a combined endpoint, you see that the patients with the atrial phenotypes have a significantly better outcome than the patients with the ventricular one. And this was recently confirmed by the group in Leiden, Schlotter and co-workers. that have shown almost the same, that both in patients who were treated conservatively and in patients who underwent transcatheter repair of the valve, patients with atrial secondary tricuspid regurgitation has a better prognosis than patients with the ventricular phenotype. So this is justifying a revision of the classification of tricuspid regurgitation. Now we have 4 different phenotypes, and in the secondary we have both the atrial and the ventricular one. Then we have the CAD-related tricuspid regurgitation and the primary form. What it is also interesting that the recent guidelines by the American College and the American Heart about the management of patients with valvular heart disease have tried to identify the characteristics of patients that have this atrial secondary tricuspid regurgitation as a patient with left ventricular ejection fraction more than 60%, pulmonary artery systolic pressure less than 50 millimeter of mercury, and no left-sided valve disease with normal appearing tricuspid valve leaflets. I have to underline that those criteria are not based on any evidence, are just agreement between the members of the committee, and some of them are really questionable, but at least is a starting point. And with this, I will thank you for your kind attention.
Thank you very much, Luigi. That was really great. And you have clarified many important aspects of atrial secondary TR. We have time for a very quick question. So you mentioned at some point how important it is the right atrial remodeling in these patients. Can you address briefly which treatment options do we have to consider before intervening on the valve, and how aggressive we should be with restoring the sinus rhythm?
Thank you. This is a very important question. Unfortunately, there is no evidence-based answer to your question, and we need more data on that. For sure, the rate control options should be really the last one in those patients. And we have learned from the few studies that we have available and a few cases that only the restoring and the maintenance of the sinus rhythm will provide the remodeling of the right atrium and the right and the tricuspid annulus to reduce or at least to slower the evolution of the tricuspid regurgitation. But which patient can be forced to death because you can predict the evolution is still an open question for future research.
Thank you very much. Now it's time to move on to the next speaker. It is my great pleasure to introduce Professor Marta Sitges from Barcelona, who will present us a case of a lady with a chronic persistent atrial fibrillation. Please, Marta.
Thank you. Thank you very much, Denisa, and thanks for the organization for having me invited to participate in this webinar. As said before, I will, and following Professor Sbadano's overview on atrial secondary tricuspid regurgitation, I will present the case of a 79-year-old lady who explains a story of long-standing high blood pressure, apparently well controlled, according to what she was telling us, with enalapril and hydrochlorothiazide. And she had chronic persistent atrial fibrillation since 10 years ago, at least known since 10 years ago. And she comes to our consultation because she's complaining of progressive fatigue, shortness of breath. She shows ankle edema in both legs. She's already taking, prescribed by her primary physician and her on-site cardiologist, furosemide. She's now taking 80 milligrams per day. Her blood pressure is 90-60 millimeters of mercury, so we have not much more chance to increase those diuretics. Her creatinine is 1.6 milligrams per deciliter, so a little bit of renal failure. Her hepatic enzymes in the blood test are a little bit elevated. And also there is a high NT-proNP. These are the values at our institution, and we estimated a neuro score for her of almost 4% mortality risk for SDS 13. And when we apply the new TRI score specifically developed for tricuspid regurgitation patients, this is a in-hospital risk mortality of 14%. This is the echocardiography of this patient, and as you can see, there is severe atrial dilatation, both of the left and of the right dilatation. There is mild mitral regurgitation, and it's definitely severe tricuspid regurgitation. If we want to focus a little bit more on the quantification, we have with this, by lowering the Nyquist, we can depict a nice PISA of this tricuspid regurgitation with a vena contracta of 15 millimeters and a PISA of 14 millimeters at a Nyquist of 33 centimeters second. These are also the measurements of the size of the right ventricle, mild dilatation of the right ventricle. As you can see here, the mid-right ventricular diameter in the four-chamber view is 37 millimeters. The area is 10 centimeters square, indexed by square meter body surface area of this lady. The right ventricular function is preserved with a shortening fraction area of 45% and a TAPSE of 18 millimeters, as you can see here. But if we go to more advanced quantification of right ventricular function by speckle tracking, the formation imaging of the right ventricle, we can see that the global longitudinal strain of the free wall of the left ventricle showed a value of 30%, which is quite preserved. And these are the volumes by 3D echocardiography, a mildly dilated right ventricle with preserved ejection fraction of the right ventricle. This is a summary of the transthoracic cardiography findings in this lady. Estimation of a regurgitant orifice using the PISA method was 55 millimeters square for the regurgitant orifice, mildly dilated right ventricle, severely dilated both the right and the left atrium, normal ejection, normal left ventricle in dimensions and also in function, and mild mitral regurgitation with normal aortic valve. As this lady had severe, or let's call it massive tricuspid regurgitation, we underwent also a right catheterization to this lady, also to exclude and to confirm that there was no pulmonary hypertension. These are the values of the findings with the right heart catheterization. As you can see, pulmonary artery pressures were within normal limits. There was elevated right atrium pressure and normal wedge pressure. So going back to this slide that was previously shown by the Professor Badano, and trying to characterize a little bit better which type of tricuspid regurgitation had this lady. So we knew she had persistent tricuspid regurgitation, persistent atrial fibrillation, and she had severe tricuspid regurgitation, which was symptomatic. So we wanted to characterize if the leaflets were apparently normal in the transthoracic cardiography. We wanted to characterize if this was a problem of the ventricle of the atria, as previously discussed by Professor Badano. We also wanted to think, because remember, there was a little bit of right ventricular dilatation. The right ventricle was not strictly normal, but also we have to think that this is a disease that progresses with time, and we are not always finding this patient at the very beginning of the course of the disease. These are three stages of the disease, as you can see on the left side of the slide. You can see almost a normal right heart, normal right ventricle with just mild right atrial fibrillation, but this, if left untreated, can progress to larger right atrium if there is atrial fibrillation with annulus dilatation. But if we don't treat this, in the end, this can progress to overload, because of volume overload, can progress also to right ventricular dysfunction. And then we have always torrential tricuspid regurgitation in these patients. So we change depending on the evolution of the disease from a type 1 dysfunction to a type 3 dysfunction. So probably we wanted to see if this lady was a little bit within this. So we went for further assessment of the geometry of this tricuspid valve. This is a zoom image of the 4-chamber view of the tricuspid valve of this lady. And here we can measure in the 4-chamber view the annulus also by 2D-dimensional echocardiography. We can also measure the tenting height, which is the distance from the annulus to the point of coaptation of this lady, which was a little bit increased, but still we could see this coaptation of the leaflets body to body. So that was, at least here in the transthoracic, there was not a very large defect of coaptation. Of course it was, because if not, there was not tricuspid regurgitation. But to further analyze a little bit this geometry, we have more advanced tools also. And let me show you two another patients, patient 1 and patient 2. Patient 3 is our patient, as you have seen. I'm sorry, let me see if I can go back to play it again. No. So patient 1 has no tricuspid regurgitation. Patient 2 has severe tricuspid regurgitation, as does patient number 3, which is our current patient. So remember that the patient number 1 had no tricuspid regurgitation. Patient number 2 had a very large right ventricle with severe tricuspid regurgitation, also enlarged tricuspid right atrium. And patient 3 is our patient who has enlarged right atrium and very mildly dilated right ventricle. So if you look at this reconstruction from 3D echocardiography of the annulus, the 3 tricuspid annulus look very differently. Of course, the one you have on the left side of the slide is a normal annulus with the saddle shape of the annulus, non-dilated and normal motion. The other two are very flattened annulus, but look at the difference of the tricuspid of the two ladies, the number 2 and number 3, where the number 2 has much more theter leaflets as compared to our patients. And this can be also depicted by numbers, by these parameters of annulus area. In atrial secondary TR, dilatation of the annulus is a little bit more enlarged, but the coaptation height, the deformation and the tenting volume of the leaflets is less in our patient as compared to patient number 2, who had a much enlarged right ventricle. And these are things important also when we plan the strategies for therapy of these patients. So we are facing a patient with symptomatic severe atrial secondary tricuspid regurgitation. She's a patient with high surgical risk because of renal insufficiency, also hepatic disease, remember, or hepatic involvement. Remember also that their enzymes were elevated. She's frail. So according to this, in the current guidelines of the European Society of Cardiology, there is the role for transcatheter therapies according to the consensus of the heart team. And indeed, these transcatheter treatments have an indication class 2B with a level of evidence C. In this setting, we went for the anatomy assessment with transesophageal echocardiography of this patient. And you can see here in this four-chamber view that the leaflets were thin, they were long, they were flexible. In this loop in the right side of the slide, which is a 130 degrees longitudinal view of the right atrium and the right ventricle with the tricuspid leaflets, we can see the gap here. There is a little bit of restriction of the septal leaflet, but it's a long leaflet. The gap was measuring 7 millimeters. Here, this is a biplane view where we can see simultaneously a right ventricle inflow-outflow view of the tricuspid valve, and we are cutting. I'm not sure if you're seeing the yellow line crossing on the anterior part of the tricuspid leaflet, and we have the concomitant perpendicular image on the right, with and without color flow imaging, so we can see that there is a regurgitant jet coming from the more anterior part of the leaflets. And also, if we are cutting the valve in the mid part of it, we are also seeing there is a large origin here of the regurgitant head in the mid and the anterior part of the tricuspid valve leaflet, tricuspid valve. Also, the transgastric view, we can see here trying to depict the central gap of originating this regurgitation. Here we measure in a still image, we can measure the largest diameter here from the septal to the anterior leaflet, which was around 7 millimeters. Also with 3D, sometimes we can confirm what we have seen in two-dimensional echocardiography. We can see the gap, we can see the origin of the jet, and sometimes it's really useful to use some lightening or post-processing of these images to really depict the whole in these patients. In case we don't have nice, also we have now the visualization from the atria and the ventricle at the same time, which is particularly interesting during the procedure. And finally, also, if we have difficulties with all these other things, but I also think it's nice to also double check and to reconfirm with MPR reconstructions, which are already available online, and that we can use them also during the procedure of the transcatheter procedure. So in this lady, and according to what we have agreed in this consensus document by the focused tricuspid regurgitation group of the PCR group, we have secondary tricuspid regurgitation in this lady with a gap which is less than 8.5. It's a central jet location. There is a little bit of tethering of the leaflets, particularly of the septal leaflet, but it's just mild, and there is enough length of the leaflets to undergo either a transcatheter H2H repair or annuloplasty. In this case, we thought that for also important, we have recently, and also this slide was shown by Professor Badano, but I want to show you the change in prognostic with the intervention. We have learned from Professor Badano that atrial tricuspid regurgitation or atrial secondary tricuspid regurgitation has a better prognosis as compared to those other forms, ventricular secondary tricuspid regurgitation. But also, if you compare the two cohorts, the conservative and the transcatheter cohort, which are those patients who underwent intervention, look at the significant difference in the prognosis of these patients. But also, if we treat these patients, they have a very good outcome with transcatheter therapies. In this case, this paper was related and only using transcatheter H2H repair. So this is what we chose for this patient. We decided to undergo transcatheter H2H repair. In this case, we use a 3-clip device, an XT with the size XT. So we started with a first clip, putting it between the septal and the anterior leaflets, close to the anteroseptal commissure to treat the initial part of the gap. With this, you can see here in the transgastric view how was the grasping. We just located the residual jet in the posteriorly to this first implanted clip, and we decided, of course, to put the second clip, where after which we between also the septal and the most posterior part of the anterior leaflet. And with this one, we achieved a very good result in this lady who, remember, had massive tricuspid regurgitation, and we left her with mild tricuspid regurgitation. So this is the baseline transthoracic echocardiography of this lady, and this is the transthoracic echocardiography 18 months after the procedure. So where you see there is still mild tricuspid regurgitation, there is very blue flow tricuspid regurgitation in the right atrium. The clips are well attached, as you can see in these zoom images there. But I want to highlight the important the important remodeling of the right ventricle this lady showed. I don't know why it's not moving. It's coming. Sorry, I'm too fast. So if you can see the slide, the video on the left side, the right ventricle was much more dilated as compared to 18 months after the procedure, where we were effectively reducing the tricuspid regurgitation, and the patient improved clinically, and we could reduce the doses of furosemide. Now the lady is only with one furosemide, one pill, 40 milligrams of furosemide per day. So thank you very much for your attention, and I will be happy to answer questions if you have any.
Thank you so much, Marta. That was a wonderful presentation. I received many questions. We have limited time, but maybe just a brief question for you. If you take into consideration the RV function before deciding to perform a cardioversion or AF ablation, and then how much can we afford to wait until proposing the patient for a procedure? Because remodeling, as we know, it takes some time.
So regarding atrial fibrillation ablation, I understood the question.
If you take into consideration the RV function when you decide whether you
yes,
opt for...
Yes, of course, we know that sometimes there is tachycardiomyopathy and there might be right ventricular dysfunction secondary to that. But I think the most important thing here as indicators or predictors of successful ablation for atrial fibrillation is more, the long-standing persistent atrial fibrillation is difficult to revert, and also the status of the atria. No? So if we have very large, very fibrotic atrial fibrillation, the probability of success of an ablation is quite low. So we focus more on the atrial function and also on the atrial fibrosis and the time of evolution of the atrial fibrillation rather than the ventricular function. So we will probably would not decline a patient for right ventricular dysfunction for going to ablation. And the second question, trying to be very fast, how much can we wait? I think to go for a procedure of treatment of tricuspid regurgitation, I think our current problem is that not how much can we wait, is that we are waiting too much. Probably we have many solutions, and probably with these patients we were waiting too much to send them to surgery, and that is probably one of the main rationale for having this not so good results with surgery, that we send these patients when they are very frail, they have very advanced symptoms, and they have end-stage right ventricular dysfunction. So probably I would advise to be quite active in promoting interventions for this patient if there is really a possibility. And I think transcatheter therapies have opened a wide range of options for these patients.
Thank you. This is really important indeed. So now it is time to move on to the last presentation. It is my great pleasure to introduce Nina Wunderlich, who will talk about interventional approaches to target the patients with atrial functional TR. Please, Nina.
Thank you so much, Denisa. It's a great pleasure to join this great webinar. So during the next couple of minutes, we have a look at the interventional approaches to target atrial fibrillation. And the things I would briefly like to touch is what kind of transcatheter treatment options do we have. The decision-making on an intervention is usually based on clinical, anatomical, and imaging factors, so we'll have a look at that. And we try to answer the question why an annuloplasty procedure is a reasonable approach for an atrial functional tricuspid regurgitation. The next question I would like to touch is what imaging is required prior to an annuloplasty procedure, and then we have a quick look at the procedural guidance. So what kind of treatment options do we have? So first of all, and this was already shown by Professor Sitkes, we have the leaflet approach, edge to edge. We have 2 devices available. And just to give you an impression, so over 8,000 procedures worldwide are performed with a leaflet approach on the tricuspid space. The next approach we have available is the annuloplasty, and about 800 procedures are performed worldwide. And we also have the opportunity, not CE mark, but we have it in study trials, to implant a valve in the tricuspid space, and about 300 procedures are performed with a valve replacement. As you can see here on the left bottom, we also have the opportunity to place a heterogenic valve. So these procedures are less frequent performed and mostly reserved for the patients who are in a palliative status of the disease. So how decision-making is done in the patients with tricuspid regurgitation? And we have to look at some clinical factors, for example. So if you have a patient with a high comorbidity or a patient with an urgent treatment indication, this is maybe not a patient for a tricuspid valve replacement. So in these patients, you would go for an edge repair or an annuloplasty procedure. On the other hand, if you have a patient with a severely impaired left ventricular function or a severely impaired right ventricular function, or even a patient with severe pulmonary hypertension, we know that these patients are not very don't have a really good benefit if we do a valve replacement. So these are also patients where we would go for an edge-to-edge approach or an annuloplasty. And another important point is if the patient is not able to take long-lasting anticoagulation, this is also not a brilliant candidate for a tricuspid valve replacement, because if you put a bulky valve in the patient, these patients would need some kind of anticoagulation. The next thing we have to look at are some anatomical factors. So Professor Sitkes already showed what we should look at during echocardiography. But if the patient is of risk of right ventricular obstruction, this is not a good candidate for a tricuspid valve replacement, more for an edge-to-edge or an annuloplasty procedure. The size of the right ventricle and the small and the right atrium are factors that should be considered. And if you have small atria or small ventricle, this speaks more for an edge-to-edge approach or an annuloplasty procedure. If you have severe calcification, there's not much data supporting that, but it might speak more for tricuspid valve replacement. Also, if you have a small opening of the tricuspid valve or a very complex valve morphology. On the other hand, if the imaging quality is very bad, we should go for a tricuspid valve replacement, because if you do an edge-to-edge approach on annuloplasty procedure, you really need brilliant imaging quality to perform your procedure. So why is an annuloplasty a reasonable approach for atrial functional regurgitation? And thanks to Professor Muraro for this very illustrative schematic, because it shows very nicely that in the patients with atrial fibrillation, we have the largest right atrial volumes and we have the largest annulus area, whereas the tenting volume is usually relatively small in this patient group. And this means that the tricuspid annulus is the most meaningful primary target for transcatheter interventions in this specific patient group. So, what kind of devices do we have available? The only device which is CE marked at the moment is a cardioband device. And as you can see here, that's a device on the right side. So, we have a polyester sleeve with radio pack markers. And around the annular circumference, we implant up to 17 anchors. And in between, there is a wire which can be cinched, a wire connection to the spool up to 5 centimeter to decrease the annular area. And in the next, just we have to go back. So in this image on the left side, you can see a surgical procedure where a ring is implanted, an incomplete ring by a cardiac surgeon, and the cardioband procedure mimics indeed the surgical procedure. So what we aim to do is to implant anchors and a band from the anteroceptal commissure, where we start up to the end of the coronary sinus. And once the band is implanted, the cinching is applied and the contraction of the tricuspid annulus can be observed. So how do we do it, and what imaging is required prior to an annuloplasty procedure? So we need two imaging modalities. First is contrast-enhanced CT, and the next one is echocardiography. So at what things have we do, or what do we have to address with the CT? The first thing is we have to exclude annular calcification. This is very rare in patients with a tricuspid disease, but this is best assessed by CT imaging. It's much less frequent than in the mitral space. But if you have annular calcification, it is a big issue because it may prevent an optimal anchoring and the optimal size adjustment after the anchors are placed. And therefore, significant calcification is more or less a contraindication for the procedure. The next thing is we have to address the length of the annulus, because the maximum band size is 120 millimeter, and we want to cover at least 75% of the annular area to get a really good effect on the reduction of the annular area. The next thing we have to look at is the annulus size, which can be done by CT as well. And we have to look at the band size. So if you look at the image on the upper right, we look at a point starting from the anteroceptal commissure to the end of the coronary sinus, and this is sized anchor by anchor. And what is also available information by CT is the proximity to the right coronary artery. So, for example, on the bottom, you see an example where we have a close relationship on the lateral side to the annulus, whereas the image on the upper left just shows a really good distance of the coronary artery to the annulus, which is a much better case because you don't have to expect any complications with the right coronary artery. So for each anchor, as you can see on the right side, there is an orthogonal view which shows you the distance to the hinge point and the distance to the right coronary artery. And you can ensure that you have enough tissue to place your anchors correctly and securely. What also can be assessed with CT is the number of leads and the rough position. You can't really decide if there is a CIAD-related tricuspid regurgitation, but you can at least address the situation and localization of the leads. And what can also be provided by CT is the optimal flow projections before the procedure. This can be predefined. By using echocardiography, you have to go through all the points that Professor Sittges already mentioned. The most important thing is, I think, is to include a primary component or a device-related tricuspid regurgitation. And as an annulus is one of the most important things during this procedure, is the annular size. We'll target this a little bit later in more detail. So the echocardiographic imaging task is at first to confirm the tricuspid regurgitation etiology. And here we see a quite good case, because if you look on the bottom image on the left, you see there's not much tethering. We have a huge gap in the middle. The gap is more positioned towards the posterior part of the valve, and we have an involvement of the anterior and posterior septal commissure. And these are usually cases which are not brilliant cases for an edge-to-edge repair. But this would be indeed a good patient for an annuloplasty. So here we see another example where we see a severe tethering in this patient. So if you do an annuloplasty in such a patient, you can narrow the annulus, but you wouldn't really have a good effect on the tips of the leaflets and on the cooptation. So this is not really a brilliant patient for that. The annulus is one of the most important measurements we have to do. And when do we do it? We do it, the measurement at the end of diastole. And thanks to Dr. Muraro, we have a good correlation, or we have the confirmation that this measurement has a really good correlation to CT measurements. So we can do that with 3D echo in addition, as you can see here in this specific patient. So let's go over the procedural guidance in very quick steps. So one very important thing is to reconfirm the size of the band. And this is something which is done by multiplanar reconstruction, as you can see on the right-hand side. And why is this important? Because the CT is usually made a couple of weeks before the procedure. And due to the volume status, which can be completely different, this should be reconfirmed that you can select the appropriate band size. During the procedure, as you can see on the left side, a coronary wire is important because it helps you to identify the tricuspid annulus. And on the right images, you can see the definition of the first anchor point, which is predefined by CT by a distance from the mid-aorta to the first anchor point. And this is procedural guidance, how we usually do it. On the upper side, you see the 3D office view, and this is helpful for the device navigation. To evaluate the distance to the hinge point, we use X-plane, as you can see on the right upper image. And multiplanar reconstruction, as you can see on the bottom left, is also a very important tool, which can be helpful to define anchor positions. Once an anchor is implanted, as you can see on the right image on the bottom, you pull a little bit on the entire system to have a look if there is a really stable position of the anchor and that the tissue is going up, and you also see an indirect shortening of the delivery system. And this would be the result. Unfortunately, the videos are not playing very well, but you could see pre-contraction. The contraction is done step by step from 2.5 to up to 5 centimeter. And you can see that there is a change in the shape and the configuration of the annulus. And I hope the last images were run, but this is not the case, unfortunately. But you have to believe me, pre-contraction, we had a massive torrential tricuspid regurgitation. And after cinching up to 5 centimeters, the residual tricuspid regurgitation was just trivial. So this was a very, very successful procedure. So we don't have big studies to support the data, but here are 1-year data results by enrolling 37 patients. And what we can see, indeed, that we have a continuous reduction of the annular area. And we also have a stable result concerning the reduction of tricuspid regurgitation after 1 year. So to close very shortly, the decision for an interventional treatment method is based on clinical, anatomical, and imaging factors. And as the annulus dilation is the main cause of tricuspid regurgitation in patients with atrial fibrillation, the annulus is particularly useful as a target structure for an intervention. So the patient selection for catheter-based annuloplasty follows a detailed CTA and echocardiography analysis of the etiology, the severity of the tricuspid regurgitation, as well as a leaflet and annular anatomy. And the results of the TRIBAN study confirm a significant tricuspid annulus and TR reduction after 1 year. And herewith, I would like to thank you for your attention.
Thank you so much, Nina. This was a wonderful overview. Very quick question and answer. Do you think that edge-to-edge repair is really an option for patients with high pulmonary systolic pressure more than 60 millimeters mercury?
To be honest, Denisa, we don't know yet. I think it's much better than replacing the valve, but we really have to figure out what is the best option for these patients.
Excellent. Thank you very much. Unfortunately, we have run out of time, so I think it was a great webinar with lots of useful insights. Don't forget to join us on November 15 for the second episode entitled Echocardiographic Imaging for Transcatheter Tricuspid Intervention, always supported by GE Healthcare. And I want to thank you all, Luigi, Marta, Nina, for your fantastic talks, discussion. Thank you all in the audience for having joined us today and for having sent your questions and comments to the chat. Thank you and see you soon.